Welcome to the Integrative Medicine Podcast. I'm Dr. Jordan Robertson. In this podcast, the best of both worlds of medicine come together, informing you of your healthcare options. This podcast is for the ultra-discerning, highly critical, and results-oriented health consumer, filtering out the good, the bad, and the real ugly when it comes to health information. As your host, my mission is to help you navigate the world of evidence-based integrative care and confidently make choices to help you live your best life. Enjoy! Welcome to our 20th episode of the Integrative Medicine Podcast. I am Dr. Jordan Robertson. I'm a naturopathic doctor, and I'm also the author of a book called Carrying to Term, and that's relevant for our discussion and topic today, where I want to focus on polycystic ovarian syndrome and how this condition influences miscarriage risk. When I work with women who are pursuing a fertility journey, I think one of the challenges that we face, or that they face as they sit in a fertility clinic, is feeling like their treatment is not really being that well individualized. So I kind of describe it as throwing spaghetti at the wall and seeing what sticks. And I think that with women with PCOS, they actually deserve a more tailored and a slightly more empowered plan to help them reduce their likelihood of having a miscarriage, but also to reduce the complications that come from pregnancy in PCOS. We know in the research that we can't just throw spaghetti at the wall. We can't just force a woman to ovulate and expect high-level results and great outcomes, meaning a baby, in women with PCOS. We know that they require a more tailored approach than that, and I think that women feel that that's not happening, and I certainly in my clinical practice will feel that that's not happening either, where we focus so much on ovulation and how women are struggling to ovulate that we fail to remember that the eggs themselves in women with PCOS are not the problem. And we actually have some really cool research that has shown that women that have PCOS or polycystic ovarian syndrome actually make great egg donors. So we can take their eggs out and we can give them to another woman, and that can achieve a successful pregnancy. And so it's actually not the egg that is the thing for us to focus on, and forcing that process to happen and forcing that ovulation has been sort of the long-standing focus of fertility treatment for women with PCOS. If we can just make that ovulation happen, because often if women have PCOS, they don't ovulate on their own, and so they may go through like extended windows of time with no period. They may have been put on the pill to try and bring on a period, but the ovulation feels like the crux of their fertility challenges. But the reality is that the reason that they're not ovulating is actually the environment that their ovaries are sitting in. It's the environment that those eggs are developing in. So if we focus solely on forcing ovulation, we're still forcing a process to happen in an environment that is not supportive for pregnancy. And that's why we see such a high miscarriage risk in women with PCOS, is that even if we do force that ovulation to happen, it's happening in the context of a very inflamed environment, and not an environment that is receptive and accepting to that egg to try and achieve pregnancy. So when I'm working with women with PCOS, and the things that I have alluded to in the book is that women with PCOS actually need to put the brakes on as far as the rush that we put women through when we're starting to approach their fertility care. It's the one time in fertility medicine where taking a pause and a breather actually may help our outcomes. And so when women approach a fertility clinic, time is certainly of the essence. We know that women are having their children young or older than they used to, and that can feel like there is a rush to sort of pursue the most aggressive treatment options possible. Women are older when they're trying to have their children, and often by the time they sit down in a fertility clinic, they've been trying to conceive for some time. So I understand that me saying, let's put the brakes on and take 3 to 6 months to prepare for this pregnancy can feel really uncomfortable for the women and the couples that I'm working with. But when they start to understand how important that environment is to grow that healthy egg, it makes perfect sense why we would want to take a pause and a breather to make sure that the environment that we're creating that pregnancy in is the most healthy and the most positive. So women are at risk of having PCOS if they have symptoms like missed periods. They may also have difficulty with weight management and difficulty with balancing their blood sugar. They may also have signs of high androgens or high testosterone, meaning they may struggle with more acne than the average woman. They may struggle with some hair loss. They may struggle with some hair growth. Sometimes these symptoms are missed early in the teen years of a patient, because often the sort of typical teen experience will have, skipped periods occasionally and may struggle with mild acne. Often women in their teens and 20s are put on an oral contraceptive pill to try and address some of these issues, which may actually mask her underlying PCOS until she comes off the pill trying to get pregnant. So part of that very sort of important process we go through with women is to actually try and identify what the challenges of her fertility or recurrent miscarriage are, so that, again, we're not throwing spaghetti at the wall, because if we can accurately identify what's going on with a woman, it makes way more sense why we would apply certain treatment principles, why we would run certain testing. So one of the things I encourage women to start with is to really make sure that she's been well assessed and that all of those areas of her hormonal health have been taken account for. Why did you go on the pill in the first place? How did you feel while you were on it? What symptoms resolved? Which ones didn't? When you came off the pill, what happened? Or how have your menstrual cycles been over sort of your entire reproductive life leading up to the moment where you decided to try and conceive? So why does PCOS cause increased risk of miscarriage? And the reason I want women to understand this is that it makes it much easier for them to be sort of the hero in their own story if they can understand the mechanism behind it. I think it's very easy to feel swept along as part of a fertility process. We're applying drugs at certain times of their cycle. You need to show up daily for ultrasounds. You feel like the entire cycle is being orchestrated. And then to come out of that with an unsuccessful cycle is just morally so debilitating. I want women always to feel empowered and like they're in a position where they can actually influence the outcome of their fertility cycle. Absolutely, there are some miscarriages that will happen, and absolutely there are some cycles that will be unsuccessful. But we know before we even start with women with PCOS that their failure rate is higher and their miscarriage rate is higher. And so it has to do with the underlying challenges that she's dealing with. And these are things that we can empower women to have a difference in by teaching them, A, what the challenges are, and B, how to evolve her lifestyle and diet and medications and supplements in order to support that. So in women with PCOS, they all struggle with some underlying insulin insensitivity. So insulin is a storage and growth hormone. It is the hormone that is required to regulate blood sugar in our body. And women with PCOS have a difficulty managing their blood sugar. It may not show up on their lab work that their glucose or their actual blood sugar levels are out of range, although sometimes that does happen. But what we do know in women with PCOS is that their insulin levels are elevated. So this hormone that is required for regulating blood sugar is working overtime to try and keep those blood sugar levels normal. And her body is somewhat resistant to the effect of her own hormone levels. So she has difficulty managing her metabolism and managing her blood sugar. So insulin is not a benign hormone, and when it's elevated, it actually changes inflammation and it creates cardiovascular inflammation. Much like we see cardiovascular inflammation and high blood pressure and challenges with blood vessel health in patients with diabetes, we see the same challenges in women with PCOS, where levels like hormones such as homocysteine are elevated. Homocysteine is a marker of vascular inflammation. And we see levels like elevated CRP, which again is a marker for cardiovascular inflammation. And so these women with PCOS, even though we tend to focus quite heavily on the hormonal consequences, they also have high testosterone. They may have low levels of estrogen and low levels of progesterone because they don't ovulate. We focus very seriously on those hormonal changes when it comes to fertility because these are the things that, very acutely are getting in the way of them ovulating. But when we take a deeper look at the underlying mechanism for why women with PCOS struggle with miscarriage, but also struggle with high blood pressure in pregnancy and also struggle with gestational diabetes in pregnancy, it's linked back to the challenges that they have with insulin. So interestingly, there have been a couple of studies that have looked specifically at why women with PCOS have increased rates of miscarriage. And we do think that some of it is related to that underlying sex hormone differences. So the higher their testosterone levels are, the more miscarriages they have. The higher their androgen symptoms are, so the more hair growth and the more acne women have, the less successful their fertility treatments tend to be, and the smaller their family size ends up being. But the real crux of it likely stems from these cardiovascular changes that women with PCOS have. So the development of a placenta, at the very heart of it, is actually the development of new blood vessels. So when the embryo implants and as we start to develop the placenta, it really requires recruitment of new blood vessels and the development of new blood vessels. And absolutely, we want that to be done very well because we know that the sort of amount of placental health that the pregnancy has, the more viable it is. That needs to be done in a sort of the context or an environment that has low inflammation and also has an adequate immune system. In women who have PCOS, however, they often have what I've coined as cardiovascular disease of the placenta. This was found specifically in a study that looked at women with PCOS who are actually undergoing elective abortion around the 12-week mark of their pregnancy. Very rarely do we get to go in and actually see what's happening at the level of the placenta, but that in this particular study, the women actually were looked at or observed around that 12-week mark as they went through a different medical procedure for that elective abortion. What they found when they compared the placentas of women with PCOS to women who did not have PCOS but also underwent an abortion at the same time in their pregnancy, the women with PCOS, their placentas were smaller, they had less stable blood vessels, so the sort of root of the function of the placenta was impaired, and these pregnancies were actually viable ones. These ones were, around the 12-week mark of their gestational sort of process, and yet the health and the sort of physiology of these placentas was remarkably different between women with PCOS and women without. So structurally, their placentas were different. We also know that insulin is a relatively pro-clotting hormone, and it actually constricts blood vessels. We know that this does this because this is ultimately how it changes blood pressure in patients who have diabetes and eventually in patients also who have PCOS. They are also at risk for high blood pressure and increased clotting as they age. So insulin promotes clotting, it promotes blood vessel constriction, and it also influences the amount of blood flow towards the uterus. When we start to pool all of these findings together, we're certainly noticing that this, as I coined it, cardiovascular disease of the placenta, is likely our most greatest obstacle in overcoming that recurrent pregnancy loss or that very high miscarriage rate in women who have PCOS. So as a listener, you may have actually been diagnosed with PCOS already as part of your fertility journey. You may suspect that you have PCOS now based on some of the things that we've mentioned so far, with the irregular periods, difficulty conceiving, high androgen symptoms like acne and hair growth. And so the question becomes, how do we do this, right? Like what are your next steps? So when I'm working with patients in-house, I'm very clear with them how important assessment is. To me, I think we need to always be barking up the right tree. We shouldn't leave any stone unturned, especially when we're talking about something as important as fertility. I think when we start to talk about assessment, we can also empower patients to understand their condition and the logic behind the treatment solutions that we bring them. To assess women who we suspect have PCOS, there's the actual diagnostic process when looking at things like total testosterone levels, perhaps a ultrasound of the ovaries, although it's questionable whether or not that should be part of the gold standard. I certainly want women to have good metabolic assessment, things like her fasting insulin, which we use to calculate something called her HOMA-IR score. And that's where we compare her fasting insulin and her fasting glucose to see how much insulin insensitivity or insulin resistance exists. I also want women to do what's called an oral glucose tolerance test, which is a marker of sort of the 2-hour before and after glucose load. We measure how responsive a woman's body is to glucose in her body. There are other androgens that we can test beyond testosterone, and truthfully, they haven't yet been highly correlated with miscarriage, although perhaps as part of a sort of comprehensive workup, I would suggest that women also have their DHEA tested and, alongside with their total testosterone. There are other blood tests, however, that fall a little bit outside those normal diagnostic tests that actually help us predict and understand the miscarriage risk. So certainly women should have their homocysteine levels tested, and I alluded to this earlier in the show. So homocysteine actually is a byproduct that our body creates as part of a very normal process. And so often when we see it elevated in patients who have low B12 or low folic acid, because those vitamins are necessary to lower homocysteine levels. So if patients are deficient, we may see high levels of homocysteine in their blood. For women with PCOS, however, the reason that homocysteine is elevated is not the same as women who are just low in B12. Homocysteine is elevated in women with PCOS because of insulin. So insulin actually inhibits a liver enzyme that specifically results in elevated homocysteine levels. And so sometimes when we see that on lab work, we can make quick assumptions in a young patient that perhaps it's related to their B12 or their folic acid. We typically wouldn't see homocysteine be elevated for cardiovascular or metabolic reasons unless patients have really well-established cardiovascular disease or diabetes. Homocystine's been thrown around as a potential assessment for cardiovascular risk. But in women with PCOS, it's elevated for different reasons. It's elevated because of insulin. And interestingly, when homocysteine is elevated independently, even if the rest of her lab work looks pretty darn good, homocysteine actually increases that risk of miscarriage in women. And interestingly, it's still in the reference range for the most part. So there was a really recent study that was done in 2019 on homocysteine, and I'll put all the references are always in the show notes. But they actually found that the women with PCOS and recurrent pregnancy loss, so who had experienced miscarriage, their homocysteine levels were significantly higher than the control group, but still were in the reference range of what we would consider to be relatively normal for homocysteine. So on the lab work, it was 11 nanomoles per liter, whereas the reference range in Canada at least goes up to 15.4 nanomoles per liter. So although they were still in the normal range, they were significantly higher than the women who had not had miscarriage and who did not have PCOS, whose levels sit at 7.5. And so I usually do suggest that women have their homocysteine levels tested as part of their assessment and workup for PCOS, because it can help guide us in understanding how influential their insulin is being on their future miscarriage risk. The other blood test that makes a remarkable difference for miscarriage rates in women with PCOS is vitamin D. And I've actually spoken about vitamin D before on the podcast and how important it is with respect to miscarriage. Just globally speaking, if women are vitamin D deficient, we know that it increases their risk of miscarriage. And it's quite a profound impact that vitamin D has on miscarriage rates, which with every point increase in vitamin D deficiency, so every point women are below sort of this ideal cutoff, it actually increases their risk of miscarriage by 1%, which if we know that most women are actually far below the numbers that we are hoping to achieve for optimal fertility, which is about 110 nanomoles per liter on lab work. It's having a significant impact. Vitamin D has been shown to be highly correlated with the severity of symptoms in women with PCOS. It seems to be correlated with the severity on lab work, so patients' insulin levels, their free androgen index, their testosterone levels all improve when we restore vitamin D adequacy. So it has a profound impact on regulating that miscarriage risk for all women, specifically women with PCOS as well. So getting into treatment strategies falls a little bit outside the scope of what we were trying to accomplish in today's episode. The purpose of this particular show is to highlight sort of the how come part of why women with PCOS are at an increased risk of miscarriage. I think at the clinical level, or even at the level of the fertility clinic, we focus so deeply on those anovulatory cycles that we forget that just creating ovulation, either that's induction from some kind of medication like letrozole, that those women are not that much farther ahead if we haven't addressed some of the underlying challenges that she's experiencing with her syndrome. And even if she does happen to achieve pregnancy, without those vascular factors and high insulin levels being addressed, she's at an incredibly high rate for prenatal complications, including gestational diabetes and hypertension, which of course is going to put both the mother and the baby at risk. And so it's important that we address these issues from the very beginning in that preconception window of time with women to make sure that we're addressing the insulin issues that she's experiencing with her condition, but also the vascular inflammation. This is why we're seeing trials on things like a low glycemic diet, why we're seeing trials on things like olive oil, nuts and seeds, fish oil. They're all having an improvement in the vascular inflammation and the high insulin levels in women with PCOS. This is why these things are improving birth outcome in so many of these research trials. It's why we're leaning towards nutrients and supplements that decrease that vascular inflammation, and that's likely why we're seeing an improvement from things like metformin, because it's addressing that elevated insulin level, which is decreasing the amount of toxicity that the placenta is being exposed to during those very formative weeks. If you've been diagnosed with PCOS or you're suspicious now based off of listening to this podcast, I would highly suggest that you engage with someone who can help guide you through a process to at the very least, understand your situation better by running some lab work, but also by having a good conversation about the impact of diet, lifestyle, and the relevance of things like medication as part of your fertility journey. There are many resources available to help women with PCOS achieve ideal glycemic control through diet. And there are resources like Carrying to Term, which is the book that I've written, and it's about all different types of miscarriage, not just PCOS, although given that PCOS is our most common endocrine condition in young women right now, it really does take up a bulk of the information in the book because so many women are struggling with either obesity or PCOS at the time of being diagnosed with poor fertility, that the strategies that we're using in those women are having a profound effect sort of across the board. The link to all of the references that review these topics are in the show notes, as well as a link to Carrying to Term, which is available on Amazon. And hopefully this episode brings to light why I see such importance and I don't want to say urgency, but emphasis on treating the whole woman with PCOS before she attempts to get pregnant. I want to avoid that spaghetti at the wall, Russian roulette style of treatment with fertility, where women going into a fertility clinic know that their underlying health and the environment that they are trying to conceive in is important, environment meaning their body, that addressing a woman's concerns with PCOS is really just honoring what we already know about fertility care, and it's that the health of the whole woman is really going to dictate how successful her treatments are, how much drug therapy she'll require in order to be successful, and also predicts the health of her future pregnancy and baby. This concludes our episode of the Integrative Medicine Podcast. As I strive to bring you the tools and advice you need to make well-educated healthcare choices, I hope you listen along. Questions about the podcast or topic requests can be forwarded to our email at imedresearchhub@gmail.com. Remember to subscribe to receive updates on the latest episodes through iTunes, Stitcher, or Google Play.